Okay, welcome everybody, and we hear some lovely baby noises to herald us in today. So one of the things I might just mention is if you notice that your computer is not on mute, it might be a good opportunity, or the lunchtime activity might come into play. It is pertinent because we are talking about eating today. So this is our 16th seminar that we are organising from UCD, Department of Child and Adolescent Psychiatry. My name is Fiona McNicholas. I'm a child and adolescent psychiatrist, and I'm delighted to co-host this with my colleague, Dr. Bloned Gavin. And we have Paul Harkin from UCD supporting us, and it's also being co-hosted by the College of Psychiatry in Ireland. Most of you are familiar with the drill, which is basically a 45-minute presentation by our guest speaker. Please use the chat function at the bottom of your screen if you want to ask questions, and I will put them to our speaker at the end of the session. And also, if you'd like to engage in the discussion, let me know and I'll call you in if we have time. I'm delighted to welcome a friend and a colleague of mine, Dr. Mima Simic, who is probably very well known to many of us, judging by the high numbers of attendees today, many of us coming from different disciplinary groups. So Mimi is the joint head of the National Clinical Eating Disorder Programme for Child and Adolescent Psychiatry in the UK, which is based at the Maudsley. And I'm guessing, Mimi, it's because of the breadth and extensive experience you have in both clinical areas, research, and indeed policy and training, you know, that has led everybody to, you know, reflect on the Maudsley, to go to the Maudsley when they're, you know, trying to optimize their own services. And I think the thing that I value very much that you bring to it is the wealth of clinical therapeutic skills, DBT, CBT, cognitive remediation therapy, the multifamily therapy. And we've been delighted to be the recipient of some of that information in our own practices. So Mimi, without further ado, I'll pass it over to you for the session. Thank you very much. Obviously, we're talking about the impact of COVID and eating disorders.
Thank you, Fiona. It's a pleasure to be again in Ireland. I just want to remark that last time I was in Ireland doing teaching, it was a week before the lockdown in UK. So this was like again coming back in the virtual reality, and the last time I've seen people in Ireland was just kind of taking off to come back to UK. That was a locking down and Ireland locking down. And the topic for today is really the impact of COVID-19 and the impact of COVID-19 on eating disorders. I want to do just a very short overview where I want to take you through today. And I would like to start with thinking about the world that had existed in March when I was in Ireland and where our service was and that period before the COVID, just to understand the changes that I'm going to talk about. And I will be talking about the changes in the service provision that we experienced during the COVID period, but also the changes that we notice and that we are observing in eating disorder presentations. All of this in COVID had incredible impact on our treatments and also the restrictions of the treatment that we have. And where I want to finish this presentation today is with the survey that we've done with the therapists and the service users, both young people and their families, since COVID restriction, about their experiences of treatment that we have been offering since COVID. So where to start? I have celebrated 20 years working as a consultant psychiatrist at the Maudsley Center for Child and Adolescent Eating Disorder. And this is really to summarize where this center or Child and Adolescent Eating Disorder Service at the Maudsley have been before March 2020. So for the last 20 years, we were the service who always wanted to be able to be accessible as quickly as possible. which resulted that after 20 years and with the growth of the service became a service that is accepting the referrals that are online, referrals that are self-referrals, and we do accept young persons referrals, GPs referrals, parents referrals, camps referrals, schools, any professional or working in the voluntary sector or young person or parent can refer a young person to the service. And what happens then is that we review the referral on the same day and we will signpost the referral within 24 hours. I don't think so it's different now than now being pre-COVID, and 20 years ago, we always try to offer the first assessment within 28 days and always to offer the urgent assessment within 7 days. Service has a very, very long tradition of offering multidisciplinary assessment, which basically means that assessment is always with at least 3 clinicians, where we use the one-way screen, we do the feedback, we do the physical examination, we do bloods, we do ECG, and we do that together, leaving the family and young person at the end of the assessment with a care plan about the treatment that we are going to provide. Service has been the pilot site in some ways for the access and waiting time, and those criteria, those standards are now and have been applicable to all specialist eating disorder services in England. From the first assessment, what happens next is that we offer the specialist outpatient treatment, and the key component of the treatment is eating disorder focused family therapy, but however, this treatment can also include individual therapy, psychiatric reviews, pediatric reviews. We have a consultant pediatrician as a part of our team, and dietitian. The mean is that 75% of the patients will require only outpatient treatment, and actually pre-COVID we were starting to get even a higher percentage of young people recovering with the use of just outpatient treatment, and the average duration of treatment was always 12 months with a median session of 27. This is not only what the service offers, so brief pediatric admission, and that's why the link with the consultant pediatrician is so important. We always had an option of brief pediatric admission for the last 10 years, with the average duration of pediatric admission of 5 days. And in 2010, same time when we employed the consultant pediatrician, we opened the intensive day treatment program, where we offer the group, the individual, family and parent support. The usual duration of a day program is around 12 weeks, and on average people attend from half a day to 5 days a week, with gradually tapering days over the treatment. We also have developed now, really 20 years ago, multifamily therapy, which is another quite intensive treatment where we work with 4 to 6 families for 4 days intensively, and then follow them up for the next 6 to 9 months. Though family therapy is our kind of focus and it's the core intervention in the program, we also always offered adjunctive treatments like pairing groups, CBT, RODBT, attachment-based family therapy. And that's how the service looked like in March 2020. We had met the criteria and the standards of access and waiting time, so everyone who came to our service at that point was seen, and the treatment was started within the 28 days, and we had like 100% on urgent referrals being seen within 7 days. Inpatient treatment was a possibility, but inpatient treatments are offered outside of our service, and the rate of admission was quite low, and over the years it was less than 5% of young people that we see in the service. So for the last 20 years, our experience and the service we developed and the service that has grown in the last 20 years was the service that was always able to assess all the referrals within 4 to 6 weeks, and within 4 weeks since adolescent waiting time in 2016, and we never had a waiting list for treatment. Over the time, what was the difference is that the team became bigger. The service finished in 2016, probably with employing 20 people, and the referrals moving from 100 referrals per year to 300 new referrals each year since 2016. There's also something that I want to remind all of us, which is linked with genes, temperament, and personality of people who are at risk of anorexia nervosa and who might, these personality traits, temperamental traits, might be something that also not only can be at risk, but can maintain their disorders. And I really want to concentrate with the middle bit. So being very sensitive to threat and seeing very easily threatening cues in the environment is one of traits that young people who are at risk anorexia are prone to. 50 to 60% of them also share anxious temperament and very low tolerance on uncertainty. So we are really talking about the population of young people who find unpredictability, uncertainty really hard to manage, and really hard to manage that things cannot be predicted, that things cannot be controlled, because this low tolerance uncertainty often pushes to the compulsion that young people need to feel that they are in control. So eating disorder becomes as a way of feeling in control, because that's one thing that young person feels they can endlessly controlled, while the world around them is unpredictable and hard to predict. I want to keep all these traits in mind and for us to think, if we have a young population with those traits who made them sensitive to development of eating disorder, what is going to happen with people who find hard to tolerate negative emotion, who are very easily threatened by their environment, who are very anxious, who have a low tolerance uncertainty, who need to feel that they're in control, and who are trying to avoid harm? What is going to happen to them, and how the whole COVID pandemic is going to impact this population? I would like you to have a guess, if we can, just for next 5 seconds. Can you think about what kind of impact COVID might have had to the population of young people who are at risk of eating disorder? So we are now in the mid-March 2020. I'm just back from Ireland. Within a week, there is going to be lockdown in UK, and the service has to change from being totally face-to-face to becoming virtually over the period of 1 weekend. We literally had 1 weekend. The week before that, everybody was predicting what is going to happen. Patients were coming and phoning, just saying, can we have the last face-to-face appointment? We did have in a day program last parents group. Parents looked at us and said, is this the last parents group? We said, this is the last parents group. And by next week, we are going to move completely virtually the whole day program. The incredible stuff of a day program, and I have to say, I'm very proud of them, and I think that really boosted their confidence, managed within 48 hours over that weekend to move all the groups into Teams, to move all the groups into Zoom, and to make a schedule that all the meals from then onwards are going to be supervised by staff, and we are talking morning snack, lunch, afternoon snack, are going to be monitored and supervised by staff on Teams as a platform that we were using for the meal supervision. The incredible thing was that at the point of the lockdown, we actually did have 16 young people in the day program. Some of them were in step down, moving from the day program. Some of them were in the mid phase of a treatment, and we have one young person who had just one day of face-to-face before lockdown came. So day program moved within 48 hours into being completely virtual. Different thing happened with outpatient service, the outpatient eating disorder service. Initially, within the first month or first few weeks of lockdown and COVID, actually the number of referrals dropped to very low numbers, much lower than we would expect during that period. And nobody knew and could predict how long COVID period is going to last. So at that point, my worst case scenario was that I was telling people, well, we have at least in outpatient to devise something that will cover next 4 months. Little we knew. And in the first month, the managers of outpatient service were really facing the dilemma. Should they delay all the assessments? And if you remember what I said, is that our assessments are multidisciplinary. It's a number of people being involved. The whole question is, how do you multidisciplinary assessment on video conferencing? So dilemma was, should we pause, delay all the assessments, or go ahead with assessments using the video conferencing, and thinking about how we are going to provide physical examination on video conferencing. We're the part of the big national training, we're a provider of a big national training. As a part of it, everyone in the service had iPad, so all team members also within a weekend could set up their iPads, and they could provide all the appointments through video conferencing. But there was a dilemma shared by therapists. Can actually the family therapy for anorexia be delivered through video conferencing? Is that the same model? How do you use model that is model with the team reviews, with one-way screen? How do you use that? And use just the video platforms, the video conferencing platforms. The one thing that was moved and transferred quickly and with the use of Zoom was the weekly multifamily for, I'm really sorry, that's Alexa being interrupting me. Is that can the multifamily be delivered? But at the same time, we were able to move a multifamily therapy for bulimia nervosa, which was a group, because it was a well-engaged group, and with no problems. Group that were very well engaged and that were multifamily group were moved on Zoom platform into working groups that we were able to finish the treatment, providing it separate groups for young people and separate group for parents, and then having just occasionally in the breakout rooms, everyone together. The new initiative in the service that during COVID was delivered for the first time were parent skills groups that were phased. So because there were so many families in treatment and many of the parents wanted to be involved in the groups. So we've done the phased parent skills groups where parents who were in the phase 1 and 2 of our treatment were attending one group, and parents in the phase 3 and 4 were attending the other group. And the groups were running over next 2 to 3 months. However, the situation changed suddenly, abruptly, by June 2020. From mid-March to June 2020, there was a gradual increase in number of referrals. And what was the first change is that we were seeing so much more severely ill people with anorexia nervosa and with really severe weight loss. Because service was still open to self-referrals, so access to service was not different. Young people could have been referred by parents, but they were not seen by other professionals. And maybe because there were no schools, no other professionals being involved, by the time parents referred young people, the weight loss was really to the level that we have not seen for many years. Before that, and especially in the last 2 years, we actually stopped seeing very severely ill people with anorexia nervosa because nobody was waiting for the referral. And what was even more striking is our consultant pediatrician continued to review face-to-face all the young people that therapists who assessed young person through video conferencing thought that they were high physical risk. And the consultant pediatrician, who has been working with anorexia nervosa for many years, made the remark that young people seemed to be much more severely ill with much more severe weight loss compared to what was reported on self-referral form or compared to the impression that the person, clinician assessing on the video conferencing had and reported to the consultant pediatrician. So at that point, we developed different protocols for parents, and the protocols were written instructions, how to measure their weight and height, how to measure the weight and height of children at home, how to take their pulse. And we also had a protocol if the family had a blood pressure machine, how to measure blood pressure and to report back to us. At the same time, the trust developed the online requests, so we could send the online requests to ECG department and to our pathology, so that parents and the young person could go to ECG department and our blood lab to get all the bloods done, so that we were able to continue monitoring some physical parameters. The big change happened in July 2020, and that big change has lasted probably from beginning of July 2020 to the mid-August. It seems the situation is calming down just in the last 2 weeks. So we suddenly had an increased number of referrals, but what was different, that by mid-July, the number of urgent referrals tripled compared to 2019. So we were getting, if people are familiar with the median BMI, we are suddenly getting young people with anorexia nervosa with the median BMI who was in 60 or low 70s percentage of median BMI. And all these young people were new presentations, And that severe weight loss really happened during the preceding 3 months since the lockdown. And for the first time, and I have to say, for the first time in 20 years, we had such a level, an unprecedented level of urgent referrals that for the first time service was unable to accept routine referrals from the end of July. And we were just focusing on working with urgent referrals. It's two factorial. One is that from having 5 referrals, urgent referrals per month, it went to 15, that it went to 20. Overall, the referrals were doubled, even for routine referrals in July. And by that time, staff was actually quite exhausted, and I will refer a bit more on how, sorry, I really have to, like it's, is one thing that you have to learn, that you actually don't, you have to completely switch the phone, not only put on mute. So what had happened is that staff was getting exhausted by then, and for outpatient staff, and it was much harder for outpatient team, because what had happened to them is that they haven't seen each other face to face since March. There were only people who were at high physical risk that were seen in the service, so not more than maybe one young person was seen by consultant pediatrician. And for the rest of the staff from outpatient service, they were told that they should continue working from home and that they should not be coming to the main building. However, at the same time, though we are getting this severely weight loss and severely anorexic patient, there was some benefits and some perceived changes in treatment that were also never seen before. What was different is that the parents were available now at all times, and they were able to provide consistent supervision of meals. They were at home. Young people liked having their parents at home. The weight gain, as much as the weight loss was rapid, for most young people, the weight gain with having parents all the time at home was also rapid. Great majority of people were actually doing really well. People in treatment, especially older adolescents, found harder that there is a lack of daily structure, and there is a lack of academic goals, and there is nothing that they can look forward regarding their academic attainment. Young people who were doing GCSE year and A levels found it extremely difficult, the lack of structure, the lack of exams, and also that they could not predict what kind of grades they're going to get. But at the same time, though this lack of structure was really hard for young people, what they found easier is they didn't need to face social situations that usually makes them more anxious, and they were not faced with social comparison with other young people, which also usually makes them more anxious. So though the severe pictures were more frequent, at the same time, the response to treatment seemed to be better than what we would expect, and seemingly was better than what we would expect in non-COVID times. Different experience was with the day program. So day program became virtual, and it worked kind of really, really well when we had in the virtual day program all young people that were engaged before the COVID. So for the engaged group, doing the virtual meals, doing the virtual groups, wasn't a problem. They continued to improve. And I have to say that from original group of 16 people, 15 of them by now are discharged, and they're discharged in really good place. The one person that had just 1 day of face-to-face really struggled, and that make us think that in order for the A programs to work, you really need a group. You need the cohesion of the group. You need a cohesion of the group of the peers, and then support that you're going to get in the group. So we decided that we'll go through extensive risk assessments, how a day program can be run face-to-face during COVID time. And we basically restarted the face-to-face day program at the beginning of July. And we, through constant risk assessment, were able to increase the number of young people who attended day program from 3 to 6, which is fewer than pre-COVID, which was 8 to 10, but was enough, like 6 young people face-to-face in the building, us wearing masks all the time, them wearing face masks all the time. And what helped us a lot is that we have a big garden, and then the groups and the meals, as much as possible, were happening in the garden. The face-to-face day program is just 3 days a week, and 2 days are still virtual, and we still is aim to move every young person to virtual program as soon as possible, as much as currently we are trying to move everyone that we can back to mainstream school and support their meals virtually at school. This is how the program looks like. So 3 days, Monday, Wednesday, and Thursday, are face-to-face, and 2 days are completely virtual, including on Friday they have therapeutic yoga, which is virtual, while we have a parent support group, which is done on Zoom. And that's how the week finishes. What is also striking during COVID is that the service caseload is around 280 young people in treatment. And I mentioned that was the average number of admission in the previous years was below 5%, but strikingly in the last 6 months, we admitted only 2 young people to inpatient treatment. One was from the virtual ITP, one of 16, and the other was from the outpatient service, and that was young person who previously was weight restored, but then she relapsed during COVID. And none of these very severe presentations that were assessed in the last 6 months actually were admitted. Some of them are in a day program, and day program has been helpful for them because it established back their eating. And where I want to spend the last 10 minutes on is on the survey that one of our clinical psychologists, Catherine Stewart, initiated and guided, and it's survey with the therapist and the service users or experience of the treatment during COVID. And the main theme has been in that survey that people were saying, we were in this together, and we didn't have a choice. We had to make video conferencing work. I just want to reflect on this article, which is saying that COVID has been a black swan for the mental health care, and it comes from a metaphor that a black swan, there was a proverb, but the black swan do not exist until they were at some point found by explorers. So what the metaphor means that there is a rare event that leads to a drastic change, and that with hindsight, that change was predictable. So video conferencing, Teams, Zoom existed. They have been existing for years, but I don't think so we ever expected that we'll be using the online platforms to the level for therapy as we have been using in the last 6 months. And in this survey, young people said who had experience in face-to-face and people who had just experienced the video conferencing. It seems that young people who had just experiences of video conferencing rated higher satisfaction with overall benefits in the therapy and ability to support in therapy, addressing the important things for them. For parents, there were no difference in rating satisfaction with the therapy. Was it only online or was it face-to-face and then online? Regarding clinician ratings of engagement in therapy that was just through video conferencing and the therapy that moved from face-to-face to video conference revealed no significant difference. All clinicians said if with the families, they had a well-established engagement. Moving to video conferencing did not change their engagement, and families who came during COVID and that were seen just through video conferencing still had a very good engagement with therapists. Obviously, there were a lot of challenges, and however, there was no choice on how the service was delivered. So people had to work through challenges regarding confidentiality, people coming in and out, being able to make sure that the doors are locked, the doors are closed, to make sure that they ask who can hear or overheard the conversation. All the issues about stability of Wi-Fi and technological knowledge of the families. Overall, I think people commented that families that are seen in eating disorder services might be of different socioeconomical background and capacity than some other families. But I have to say that families seen in our DBT service or forensic service, actually video conferencing is working, and after initial glitches, people get a handle of it. There are some real benefits of having video conferencing as a new media for delivering therapy, because you were helping young people, families with having conversations in the context where the change should be happening. Therapists found really indicative seeing meals in the client house, and they have a better insight in their difficulties. I was definitely surprised with the amount of mirrors that young people have in their bedrooms. All these young people have a body image dissatisfaction, and actually their bedrooms are covered with mirrors. So it was easier to address in therapy for the first time the whole notion of being surrounded with mirrors and the meaning of that. And also people providing the virtual meal support. They were able to coach and had parents and had many more opportunities to help parents at home support them, to support young people in finishing their meals. There are differences in obviously in being together with young people and their families in virtual, online video conferencing world, and there are a lot of differences for the therapist. It's about not being able to see anyone, not being able to see nonverbal, subtle facial expression. It's harder to tolerate silences in therapy. It's harder to address high expressed emotions when the family members are sitting together. It is also a hindrance that families are not able to see each other's facial expressions, so they have to check all the time with each other. At the same time, therapists have been pushed into being more creative and using Teams, Zoom, and sharing materials, sharing handouts, using the clipboards to work with the young person was very imaginative and seemed very beneficial. What challenges? How do you work as a multidisciplinary team? Though currently we are doing multidisciplinary assessments again, though people are joining on the same platform. There was a great loss for outpatient team that had no face-to-face contact of spontaneous interaction with other team members. And it's really more challenging for them to keep morale and enthusiasm than for the day program team, who still have days when they meet face-to-face with mask, but they're still having physical presence of each other, and it seems there is something very healing about that. But at the same time, it brought the confidence to the team and the cohesion that was never seen before. I think in outpatient team that is just providing therapy through video conferencing, for therapists find hard to maintain their confidence, and also blurring the boundaries between home and work has been provided challenging. And they commented it would be different if the online therapy was delivered at work, and it's different from delivering online therapy from home. So overall, and maybe you already are experiencing this screen exhaustion, definitely we all started to feel tired and fatigued with screens, and no wonder that big companies are introducing extra annual leave because of exhaustion due to overuse of screen. And I just want to finish going back to the young people and parents survey and comment on the question that was highly relevant. Would you like to meet online after restrictions lifted? And there is a difference between young people and parents. So for young people only, less than 6% said that they would like to continue to meet the therapist online. And still majority would say, well, they don't mind, it can happen. Still, the percentage of young people who would like appointments with the therapist face-to-face is high, is over 46%. What is really interesting, that is different for parents. So parents, and maybe it is about commitments, about commuting, if you see greater majority would not mind or would prefer to continue seeing their therapist, their child's therapist online, with less than a third saying that they would prefer face-to-face contact. So it's going to be interesting what kind of level of changes the COVID will result in mental health and delivery of therapy. So I want to thank you, and I hope that we have some time and that I would really like to answer your questions.
Mima, thank you very much for the talk, and for, I suppose, reminding us how certainly you described over a weekend how suddenly a very, very huge service changed rapidly and effectively, by the sounds of it, from routine clinical practice to virtual. I'm in awe of the fact, not in awe of the number of referrals you get, that's scary, but in awe of the fact that within, a day you can screen, within a week that you can pull people in, and within a couple of weeks most people are in treatment. I am wondering how much of it is a consequence, do you think, of adequate resourcing or skill set and expertise, and the fact, that the Maudsley service has been running very effectively for years, and, whether it's kind of a lean machine at the moment?
I I don't know if people are aware of extra funding that came before 2016 for the specialist child and adolescent eating disorder services, very specifically for the eating disorder services. So currently in England, there is 71 specialist eating disorder services, and some of them are better and some of them are kind of, there is a difference in resources, and I would imagine our service is considered to be the service that has quite a bit of resources. But most of the services now in England are operating according to the standards, and the standards are 7 days for urgent, 4 weeks for routine. And I think overall 80% of services were meeting the standards before COVID.
I know we're joined today by our own colleagues who either Sarah has led, or Michelle, who is leading our own clinical eating disorder program. And I guess maybe towards the end they might like to come in and comment, but certainly it's a fantastic position to be in where, you know, we all know the earlier the intervention in any mental health issue is important, but particularly for children who can lose weight precipitously and become very medically compromised. And I think you were saying during COVID, you saw that. And anecdotally, it's interesting, in our own hospital in Crumlin, we saw an awful lot of very significant 20% of body weight loss in a couple of weeks. And similarly in the community services. I'm going to, yeah, go ahead.
No, I just wanted to say that's why I started Needs for Control, and I do think that kind of young people wanted this severe weight drop because that's a way of controlling and dumping the anxiety about the world that became unpredictable around them.
Out of respect for those that have asked questions, I might just get to a couple of the audience questions. So Diana had asked about a little bit like the black swan effect. Do you think that services will continue? You're managing very well virtually. You know, there's half and half between parents and young people who wish to continue that way. How do you see services going? Let's assume we get a vaccine sometime next year. How do you see services going when we can meet face to face again?
Prediction. I will tell you about day program where we have a mixed model. I think the level of mixed model is going to stay. In London, the commuting and how much commuting takes time and we have now the evidence that online therapy can be beneficial. So I do think we will in day program really do the mixed model, trying to get people into the schools and providing meals virtually, supervising meals virtually at school. That will be one change that I can predict. People will also be deprived of face-to-face contact initially. I think there is going to be a move towards wanting to see therapists, but at the same time, and especially if the commuting is a problem, we will be using, I think, much more video conferencing. I think it's going to be interesting now in September when people are going to school and parents are going back to work. So we are in the new phase and we are thinking, are we going to have sessions now, parents at work and a young person at school together?
One of those, I mean, even thinking about the blended model is often very helpful by way of initial assessment, engagement, therapeutic alliance and all of that. But also importantly for being able to set up that medical baseline assessment. And Jerry actually asked one of our audience members, you know, like how can you even currently facilitate the remote monitoring of things like blood glucose or weight? You mentioned all right that you'd ask your parents, you know, to take their pulse and the BP if they could. I assume that also was weight monitoring during the weeks.
Yeah. Weight monitoring during the weeks is actually done by parents, yes. We do have that possibility to ask the PET lab to do the request online, and then if we are physically worried, we will still send the young person. When I say we'll ask parent to bring the young person to our PET lab at the Maudsley hospital that is still working.
I guess I'm also a firm believer in that clinical symptoms, really must not be forgotten. So a blood glucose, you probably have a lot of clinical symptoms of low blood sugars, prior to a need for an urgent blood glucose reading. It's about the combination of maybe, did you do anything by way of your non-medically trained or nursing trained colleagues in terms of helping them ask about?
Absolutely, they know the basics, and the doctors are joining video conferencing therapy sessions to check all and ask all the questions about dizziness, fainting, all that might indicate that there is a physical risk. So the therapist can still bring through video conferencing the doctors in who are going to do online physical assessments.
There was another question by way of specific recommendation for the mirrors in the bedroom. How might you advise a young person about that?
I kind of work pros and cons now. I was mentioning that because I was actually surprised how many of them had huge mirrors, like body-size mirrors in their bedrooms. So we overall, in the certain phases of treatment especially, are kind of saying, remove the mirrors, cover the mirrors, kind of do that. And I don't think so we ever checked properly what young people, how the bedroom of young person looks like. That was the surprise. Like everywhere there were these huge mirrors.
Right. Would you said you incorporated into the treatment, you had something very concrete to go on.
Yeah.
Do you recommend to the young person, if that's an issue for them, to cover them up, or
to cover them up, to kind of remove them temporarily, because there is such a checking behavior usually. Most of them have quite a lot of checking behavior with the body image and with the mirror being present all the time.
There was a specific question by Charles, and I apologize to many of the FBT trained clinicians out there, because this is very familiar to you. But Mima, could you say a little bit about the specific family type treatment you offer? And maybe not all of the audience are familiar with the model.
We offer family therapy for eating disorder, which is not equal FBT. That's what I want to say. There are some kind of our differences and distinctions. We have like 4 phases. We work very much with engagement and formulation. We try to individualize kind of treatment a bit, though the basic principle, the overarching principle, is to help and support parents to overview the meals of young person and help and support young person to weight gain. So it is the first phases of treatment is using parents as a resource, using family as a resource to help young person reestablish regular eating and weight gain. And then the next phases are about individuation and helping family and young person with uncertainty, intolerance of uncertainty, anxiety, growing up, all the triggers that might have and anxieties that predates eating disorder.
I suppose one of the difficulties for families during this time, which everybody has experienced, is the additional stressors that COVID has brought by way of some families socioeconomically, change in working conditions. In some ways, having both parents at home working from home might have unearthed, the fact within family therapy where you're encouraging the parents to take charge together and work together. It might have exposed the fact that actually one parent really isn't doing it or sabotaging the other.
At the same time, as I said, the experience was that because parents were focused and were able to provide supervision, they had to go to work, they are not at home. Most young people actually have done well.
So the fact that maybe you could argue the flip side, parents are aware what the kid is or is not eating, and maybe having the whole family together. In anecdotally with cases that we've seen, it has gone either way. For some, they welcome sitting down as a family and they find it easier. And for other children, all the meals being heavily supervised, has just been far too intense.
Also kind of what has changed over the years and where we are different, we do coach much more parents now on their own and on using distraction, how the whole tension around the mealtime can be managed in a different way. So that's the change. We will do the separate sessions with parents just to help them out how the mealtime can be more tolerable for young person.
Yeah. And again, I think, that's partly maybe reliant on the expertise and the confidence of the therapist to know when, they can deviate from, the model to either breaking it to just supporting parents or indeed just supporting one parent, and having split Zoom sessions where a child might come on for some or all of it, or in some cases, none of it.
Yeah.
Another just both some comments coming in about, they've also seen increased referrals during this time. And Sarah, who's a pediatrician, who we had just got up the simple model in Lucina of a standardized integrated medical and psychiatry model looking after the eating disorders, only to be suddenly faced with the fact that we couldn't be inviting people as often to the hospital because of risk of COVID. But Sarah has also said that they've seen in Temple Street significant lower ideal body weights, young people coming in. Could I flip it around and just ask you your thoughts about the reverse side of it? So we've been talking about a clinical population of eating disorders, most typically the anorexic group. What about within the normal population in terms of eating habits of people during this time? The fact that, there was a huge increase to the takeaways when the restaurants were closed. And we're all aware that the nutritional value of many takeaway outlets is not optimum. I mean, obviously, you have some excellent ones. And the fact that people are at home and grazing all the time, the fridge is full, you're at home, you're looking for a break. Has there been much written, or are you aware of it, about the eating patterns of the general public?
Just heard from a friend from Canada that there is a term, COVID fat, which basically means that most population has gained weight during COVID. I don't know if there are figures around that, but people probably reacted differently as we do to situation that seems so much not in our control. I do think that also, at least in UK, Boris Johnson is very clear that the nation should lose weight because obesity is a risk factor for COVID. So he done quite a lot of speeches, which made some of our patients, one of our patients actually wrote a long letter to Boris Johnson explaining how detrimental that is for people with eating disorders, saying to whole nation that they rapidly should lose weight. So there are...
I mean, that's always going to be the dilemma with the public health message. There is always going to be somebody who's going to be at risk by taking on what's otherwise sensible message. And indeed, Boris himself did well because he lost quite a lot of weight during the period. It's fascinating to me to see the whole link between obesity and COVID in terms of the immunological responses, the inflammatory responses, the antioxidants. And the other area I've been fascinated with is the link with vitamin D, where lower levels of vitamin D not only increases your risk of being infected, but increases the risk of a negative outcome. And again, going back to both the normal population and indeed even the vulnerable elderly population, who are often, we're all in Ireland and England, you're not much sunnier than we are over here, but we're all going around with, low levels of vitamin D. Whether within our eating disorder group as well, we should actually be regularly supplementing advocating multivitamins. I don't know what your thinking is there in the UK.
Our pediatrician anyway always tries to supplement vitamin D. We do check vitamin D. This is pre-COVID, and we try to supplement vitamin D anyway, which is low in people with anorexia. On the other hand, I have to say we didn't actually have in our population, young people population, much COVID at all. If one case of COVID. At the same time, the staff in our day program, probably in our inpatient staff on antibody testing, we were positive 30 to 50% with antibodies. So I didn't see any increased risk in the population. I'm not saying it does not exist. I'm just saying we have not seen many young people who were at least having symptoms. Doesn't mean that they were not positive. And at the same time, I know that probably 50% of my staff actually had in March were positive for COVID.
So 50% of who were positive for COVID?
Staff.
Really?
Yeah.
Gosh, that seems to be tremendously high.
Yeah, it's commuting. It's probably because of that. So kind of all inpatient staff in our hospital, and because we were all tested for antibodies, like there was definitely a number of people at work in March who had COVID and were positive, and young people who were around them definitely didn't have any symptoms.
My understanding from London is that the rates of antibody positive was about 17%. So it's much, much higher. I don't think we have been testing ourselves as much. I'm amazed in Crumlin that I haven't heard of any of my colleagues. And I don't know whether it's the same for everybody in the group, you know, whether many people have had COVID. I know we're at risk by virtue of our clinical work. Yeah, and I suppose it depends on how many of us have been able to work virtually as opposed to coming in. Mima, before we finish up, Michelle Clifford, who runs the National Eating Disorder Clinical Programme, has technological difficulties, otherwise would have asked herself. But she just wanted to ask about, thank you for your talk, she wanted to ask about, are you doing virtual new assessments? Have you started or considered that? I know we've been less likely to do that in Lucina, but have done some. And the other question was, how long do you think a young person should be in the day program before they might switch to virtual? Now, I don't know if you can answer.
The virtual kind of assessments, outpatient is doing only virtual assessments. So our outpatient eating disorder service doesn't do any face-to-face assessment. They do virtual assessment, which is slightly shorter. It's now 90 minutes, but there is always a doctor and an assessor and a note taker on the call, on the video call. The day program does face-to-face assessments, and it's very individual how quickly young person from day program can go virtual. What we have anyway is that in the day program we do have constantly 2 days virtual, so we can test it very easily how they're doing virtually with the online supervision of meals. And we try to move to virtual as quickly as we can, because we never know when we're going to be told again to stop. Yeah. So the whole, I have to say, goal that we have this summer is to have a new group of people, because all people that were in the day program at the beginning of COVID have been discharged. So we established a completely new group of people, trying to engage them for a group, so that if any point in September, October, if we have to move back to completely being virtual, we have a good group in a way that they are really engaged group.
Right. And what about trying to have some social contact or benefit of group dynamics? Do in the day program, do you have group activities? Do you?
We have groups. We run the psychotherapy groups. They are with the face mask if they're not in the garden. In the garden, you don't have to have a face mask. inside you have to have, but we do face masks, but we do run groups. We done all our models. We run CBT for Impressionism, RO.
When you switch to virtual, do you try and continue with that component?
Yeah. All the groups are also possible to deliver virtually. Yeah. The content hasn't changed. It just moves in between face-to-face and virtual. And still, it's delivered to the group of young people.
And so it sounds like in terms of your adult colleagues, have they followed similar pathways? Have they kind of moved to kind of virtual as well?
They moved completely to virtual. They stopped for a while and then they moved to virtual, and they still don't have any face-to-face.
So it'll be interesting to see how things go, because now that school, and we have to finish unfortunately now, but now that school has reopened, not yet in the UK obviously, but it has in Ireland, and already as expected and predicted, you know, there have been some school closures and some small outbreaks, but it will be interesting to see, you know, I guess we have to readjust, you know, we kind of thought, right, everybody back in now, but it is a question of, you know, maybe taking the good from the virtual and, you know, as you have said, and one of the audience, Liz, has also supported that idea of, you know, making sure that our technology is supported. And if we are doing Zoom, well, I'm delighted that your Alexa has stopped talking to you during this.
That's kind of too much technology. I completely forgotten that the Alexa talks to me. That's something that I have to kind of catch up with my own technological adventure.
Well, I'm so far behind you, Mima. I haven't managed to set a relationship with Alexa yet. So that's to come in the future. So could I just thank you very much for presenting to us today. The comments by the audience, you know, certainly attest to the fact that they were delighted with your presentation. We've had huge numbers on it as well. I think it must be our record Zoom attendance. But I'd also like to thank the attendees as well, as always, for spending your Friday lunchtime with us here. Just to alert everybody, Paul, I don't know what slide you have up next, whether it's the October conference or next week's seminar. So next week, I'm delighted to let you know that Professor Russell Viner, who's the lead of pediatrics in the UK, consultant pediatrician, is going to be talking to us about transmission within children and adolescents, which has been an area of much debate, and I think is very pertinent as we start back in the school system. So please do join us for that next week. And then the last slide should be, if Paul has it, super. So this is just on occupational stress and burnout amongst healthcare workers. And really, I think we're all beginning to realize that we might have been great at the sprint at the beginning, but we are now, you know, digging deep into reserves, and we're realizing that actually, you know, it's not only a marathon, but it's going to be going up the hilly climbs of Wicklow Mountains, up and down and up and down. And hopefully this conference will address some of those issues for us. So thank you all very much, and see you again next Friday.
Thank you. Thank you. Thank you.